Good morning, everybody, and very much a pleasure to welcome you to our 36th annual Fraser Gurd Visiting Professor Surgical Research Day and Graduation Day. And of course, as you know, this is such a critical and important moment in our academic year, really a highlight of our academic year, where we take a pause in our usual activities for the chance to see highlights of our department's research and most importantly, celebrate with pride the accomplishments of our graduating residents and our students and fellows. And this year, I'm absolutely delighted to welcome Professor Mark Emberton, Professor of Interventional Oncology for the Division of Surgery and Interventional Science at University College London. Professor Emberton also served as a Dean of the UCL Faculty of Medical Sciences for 10 years up until 2025. Professor Emberton is a urologic surgeon whose research has improved the diagnostic and risk stratification tools and treatment strategies for men with prostate cancer. He leads a clinical innovation team that implements and evaluates new imaging techniques, nanotechnologies, bioengineering materials, and non-invasive treatment approaches, such as high-intensity focused ultrasound and photodynamic therapy. But he's also interested in many other aspects of evaluative research, such as clinical approaches to evaluation, alternatives to randomized controlled trials in surgery, design aspects of diagnostic studies, guideline and methodology, and how we evaluate and produce evidence-based practice management policies. The very active researcher, to put it mildly, lectures all over the world. He's published over 600 peer-reviewed articles in some of our most prestigious journals. But really, I think most importantly, is an example of taking new ideas and through good science and rigorous evaluation, seeing those ideas become part of routine practice and really changing practice all over the world. And in recognition of his work, he was actually appointed an Officer of the Order of the British Empire in 2021 for his services to prostate cancer research. So we're really delighted to have Mark with us. I think we had a great meal last night at Ferreira. I think he heard enough about our hockey team, and I know he's a huge fan now. Was very upset with the result of yesterday. So welcome to Montreal, and thank you for being with us today, Professor.
A true pleasure. Yeah, a true pleasure. So it's lovely to be here. Montreal's a kind of second home. I think we were trying to count how many times I've been here. I think it's kind of 6 or 7 times. And I was telling Leanne yesterday that the first time was in '67 when I came for the Expo '67 as a 7-year-old. So that gives my date away. But it's a wonderful moment to be here to celebrate Dr. Gurd, who obviously was a kind of key director of surgery in Montreal. And like many surgeons in the kind of post-war era, he was interested in trauma and the metabolic response to injury. And I suppose, and also was a wonderful clinician scientist or surgeon scientist that we're all going to try and emulate today. So it's a wonderful memory. And as a kind of tenuous link, he was very interested in the metabolic response to injury. I'm going to explore a kind of tissue response to injury and see whether understanding that can help us improve patient care. But before we do that, let me tell you a little bit about where we work and where I come from. And we had a lot of this discussion yesterday, and it's always very, very hard to understand other people's healthcare systems because they make little or no sense unless you kind of work in them. So here you can see 2 buildings, and so the older building is the university, that's University College London, and the blue building, the newer building, is University College London Hospital. And although they sound very similar, they share key words, they're actually very different and distinct and completely independent institutions. So unlike some parts of the world where the university owns the hospital or the hospital owns the university, here we're completely separate. The hospital spends taxpayers' money in the NHS, poorly, apparently, and the university obviously has to generate income in the usual way through student fees, through enterprise, through philanthropy, and through grants. And we have to work through partnership, and I'm appointed to the university, but 50% of my time is attributed to kind of hospital work or research work, inverted commas. So a lot of it is just work by agreement. The contracts are deliberately kind of vague, and that's the kind of setting in which we try and innovate clinically. So it's our birthday, almost to the date. So we're 200 years old this year. It's an important moment because when UCL was created, it was created to kind of break the hegemony of Oxford and Cambridge, which needed doing, although they'd been around for many, many hundreds of years. If you went to Oxford or Cambridge then, you had to qualify in many ways. You had to be a man, you had to be independently wealthy, you had to be Church of England, and you were very limited in the subjects that you could choose to learn. And they include divinity, Latin, et cetera, et cetera, some of the very kind of classic teachings. You couldn't go there and learn modern languages. You couldn't go there and learn engineering, for instance. And so a new university had to be created to break that. And this is the picture showing the first intake of women in their own right at UCL 200 years ago. So it has that slightly disruptive spirit, which we're trying to kind of re-engender with the 200-year celebration, which is kind of ongoing and will peak in the summer when the date falls. So we work like you in a distinct urban environment. Many of you will have visited London. I think just to orientate you, if you walk that way, according to your view, you get into central London. If you walk that way, there is Regent's Park. So we're about a kind of 10-minute walk or a 5-minute cycle from central London. And you can see the hospital labeled UCLH, which is the new bit there. You can see the kind of neoclassical building of the university. You can see the old University College Hospital London, which is built like an old TB hospital to encourage ventilation in the various wings. That's now the medical school. And slowly over the years, through mergers and acquisitions, that we built up a kind of campus now, which is close to the university, but very close to the various hospitals. And you can see our Cancer Institute, Cancer Center, and some of the other hospitals that used to be in places like Covent Garden have been sold off. For instance, the ENT hospital now is this building here. And so that's how we work, and it's very leaky. It's deliberately porous, and clinical academics move from hospital to university to hospital all the time. And of course, like yourselves, we're not a cancer center, we're multidisciplinary. I think the only thing you can't do at UCL is music. You have to do that at Royal College or the Royal Academy of Music, but every other subject you can do, including fine art, etc. And obviously, with modern science, we need to go broad. You know, there are legal aspects, there are ethical aspects that often need to be considered, and increasingly now, with computation, we're working much closely with engineering, computer science, etc. And so being part of a kind of multi-faculty university is critical, I think. And this has become known as the knowledge quarter of London. And the reason for that is that some of you might recognize, so the blue dome here is the British Museum, the British Library is here, and the Francis Crick Institute, which is a standalone research institute, is there, and obviously all the kind of UCL buildings. GSK have just moved from near Heathrow to central London, so they're just off the picture here. And a lot of biotech are moving in as offices become kind of emptied because they're not used as often as they used to be. And so slowly, this kind of part of London is becoming a real kind of biotech center. And obviously we have a lot of hope for that with future collaboration with kind of industry, etc. So the subject of my talk today, we deliberated quite a bit on what to talk about. And this is an attempt not to bore every non-neurologist in the room. And so we thought we'd choose something that most of us do. Most of us sample tissue to inform clinical decision-making. And I thought I would reflect on changes in the prostate world, which have been quite dramatic, and we're just kind of learning about that, and then project into the future about where I think this might go and how we might drive it by building an evidence base. And a lot of this is possible because of work that has preceded this, and that's largely based on imaging and its attempt to recapitulate the underlying microstructure of the prostate. So the urologists in the room will know that actually not that long ago, everybody had a biopsy. If you were deemed to be at risk or your PSA was high, it was a biopsy. There was nothing else available. There was no triage test that could discriminate disease from non-disease without going to a biopsy. And that was the case everywhere, just 6 years ago. It's still the case in many parts of the world. If you're not insured in the USA and you're rural or Medicare, that's still the case in 90% of patients. You still go straight to biopsy. You don't get the opportunity for a triage test. Today, in certain jurisdictions, about half the patients can avoid a biopsy. That's probably the extreme. I suspect patients in Montreal are somewhere between 0 and half. I think that's where most of the world is now. But the issues driving that are really quite interesting. So I think it's legitimate to ask, wow, this has happened rather quickly. So about 5 to 6 million biopsies are done globally every year. Prostate cancer, if you take skin cancers out, is the most common cancer in the world. This is a dramatic change in management, which has happened over a relatively short time. And remember, part of that time was during COVID, where it was very, very difficult to innovate clinically. But first, I think just a little bit of history for those that don't know this story. So this is Hugh Hampton Young, allegedly the first prostatectomist from Johns Hopkins. So this was about 120 years ago where he removed the prostate. And since then, until very recently, all men were biopsied and all men were treated at the whole gland level. So there was no other opportunity. If you had cancer, you had to have your prostate removed or more recently irradiated. There were attempts historically to try and image cancer. Is there a test that we can use that will tell us whether cancer is there or not without sticking more and more needles into the prostate? An ultrasound came about in the kind of late 70s, early 80s. There were very heroic attempts to see if it would work. And I think it's fair to say that it could visualize the prostate, certainly in the early days, but it wasn't good enough to discriminate cancer from non-cancer. That now has changed due to work done in Canada, which has now been floated as a company, and that's using very state-of-the-art high-frequency ultrasound. And then there was a paper in the 80s, and this could go into a collection of really bad papers that changed practice. This was a randomized trial of 55 patients that changed practice for 50 years, in that it said that the yield of cancer was higher if you did random biopsies knowing where the prostate was, i.e. using the ultrasound to tell you not where the cancer was present, but where the prostate was, versus using your finger to get onto the tumor and then biopsying the tumor that you could feel. So that was a clinically directed biopsy versus a random biopsy. This paper showed, as did others, Stamey and Hodges' paper is the other one that is famous for this, that you were better off, inverted commas, doing a random biopsy using just ultrasound to tell you where the prostate was. And that lasted 50 years. And probably in retrospect was the driver of the overdiagnosis, overtreatment issues that have bedeviled the whole screening discussion. The UK screening committee has just commented about 2 hours ago. I got an alert, and they've also decided against screening because of the overdiagnosis and over-treatment issues associated with it. And it's this 50-year kind of change in practice that we're just starting to challenge. And it's important here that the ultrasound was used not to tell us whether cancer was present, basically just to show us where the prostate was. And what we were doing largely was picking up indolent disease that we know to be present in most men as they age, from which very, very, very few men are destined to die of. And then MRI came along. This is the first report I could find of prostate MRI. I think you'd really struggle to see where the prostate was if you weren't a real expert. But this was about 1982, very, very early days of the MRI. Again, not being able to discriminate cancer from non-cancer. We got involved, this paper is late because Caroline Moore, the first author, was having her third child, I think. I'm going to talk about Caroline Moore at the lunchtime meeting as a really fantastic example of a surgical scientist. But these were images from 1998 in which we used, just like Montreal, we were doing some early work on photodynamic therapy, and we needed a test to tell us whether or not we'd done anything to the prostate. We couldn't see on ultrasound, so we tried it with MRI. And I think this is probably one of the first images anywhere in the world of a treated prostate. So this was the beginning of our immersion into imaging. 10 years passed, and obviously a lot happened during that time. There were many single center papers from Lille, from other parts of the world, from Australia, showing that MRI had some role. But this was the culmination of a multi-center study that we did to try and shift the kind of guidelines, which until then had said, there's no place for MRI in the prostate cancer pathway, and was a diagnostic study in which we compared the new test, imaging, MRI, against the standard of care, which was 12-core biopsy at the time, versus a very exacting reference test in which we sampled the prostate every 5 millimeters. This was an extraordinary gift that the 563 men gave to allow themselves to be biopsied to that extent. And it was really exposure of that reference test that allowed us to calibrate the performance characteristics of imaging versus the standard of care, which was 12-core biopsy. And you can see that this exposed the inaccuracy of the 12-core biopsy. It showed that you are better off tossing a coin than subjecting a man with a prostate to this test. And rather amazingly, and this is quite rare in science, that the new test that we were evaluating was twice as good at detecting, not 10%, not 20%, but twice as good at detecting clinically significant prostate cancer. This was dramatic, but interestingly, this paper didn't have that much of a splash. It was a kind of technically complicated paper to read. The results were kind of difficult. It wasn't a randomized trial. It was a kind of starred compliant diagnostic study in that everybody got every test, and so wasn't enough to shift the dial. What was important, and obviously you'll know this, so if you have a high sensitivity and a negative test, you can rule out disease with a lot of confidence. And the negative predictive value that came out of this was in the order of about 95%. So suddenly we had the beginnings of a test that we could use as a triage for men at risk to try and avoid a biopsy. But it was a little bit early to do that. And so whilst we were recruiting to this, and it was very hard to recruit to, especially towards the end. And interestingly, from a kind of research perspective, I didn't manage to recruit a single doctor into this study. They just said, I just want an MRI. I don't want the 40 or 50 biopsies that the trial requires. And so it showed the importance of timing of these trials. If you do it too early, you won't get ethical approval to do it. You do it too late, practice changes, and you just can't recruit. So towards the end, it was quite a race. And so we started thinking about whether we could randomize, so whether we had enough information at the time to do a randomized study to randomize men to standard of care, 12-core biopsy, versus a biopsy only if you had a lesion on MRI. And this was at the time, which is kind of weird to think about, extremely radical. And in fact, several people thought it was unethical to not biopsy certain men. Anyway, we managed to complete it. And the reason we managed to do it is that a lot of people wanted to start doing MRI but couldn't because their institutions didn't let them unless they did it within a trial. And so this was enabling and facilitatory to get MRI up and running. So again, showing the importance of timing in succeeding recruitment to trials. And so this showed that biopsying some men with fewer needle deployments and limiting that to the area of abnormality of the prostate was superior at detecting clinically significant disease compared to biopsying everybody. So suddenly we had, level 1 evidence that actually we could biopsy fewer patients, biopsy them better, and find more clinically significant disease. And moreover, there was a halving of the proportion of men with clinically insignificant disease. So we were halving the problem of overdiagnosis / overtreatment. And this landed with a bang. People can understand an RCT. It was sufficiently bravely designed to be quite clear in the results, and it was amazing. Promise had very little impact on practice. Precision, this one, had a huge impact on practice, which happened really, really quickly. And this is NICE, National Institute of Clinical Excellence, or now Clinical and Care Excellence, and they were really quick to issue pretty bold statements. And this was April 2019, so 6 years ago, almost to the date. And they said, offer, not think about or consider, offer multiparametric MRI as the first-line investigation for people with suspected clinically localized prostate cancer, and report the results using a standard Likert scale. So that was good. So do an MRI on everybody in the most common cancer, even though we haven't got enough MRIs to diagnose and manage all the patients we've got already. This was pretty bold. Offer a MRI influence biopsy, so use the information you get from the MRI to target the area of maximum probability in those men that had a lesion, in other words, scored 3 or more on the scale. And for this talk, really importantly, this was the first guideline to suggest that you could use this triage information to avoid a biopsy completely in men who had a normal scan, which to many of you will sound crazy. You don't biopsy a normal brain, a breast, lung, kidney, liver, but urologists still insist on, or actually they do in many parts of the world, of biopsying what looks to be entirely normal. And this was the door that was then rendered partially open, so we could explore the degree to which we could triage men to avoid a biopsy and only biopsy those that really needed it. And just to let you know that the world doesn't stop there, that technology continues almost at a pace that is very hard to adapt to, that will help us subsequently and downstream. And so this is a bit of post-processing one of our team have done. This is commercialized now and looks at the diffusion scan. And you can see now that we can recapitulate the underlying histological architecture in a way that we couldn't do before. This is luminal water fraction imaging, so another sequence that we've developed, which is a 5-minute scan with no injection, so you don't need a doctor present. This is under trial, and it actually, again, tries to recapitulate the underlying structure of the prostate in terms of calculating quantitatively the kind of proportion of lumen versus tissue. And in cancers, you have less and less lumen as the cancers invade the structure of the prostate. We'll see whether this has kind of marginal incremental benefit, or indeed can stand alone as a screening or indeed a triage test. And then just around the corner, I mean, carbon-13 hyperpolarized scanning is very expensive, very difficult to do, but that's about to change. There's a German company now that's completely revolutionized everything. And so they basically developed something that looks like a refrigerator, and you can do 40, 50 patients a day. Currently, we can do 1 a day at great expense, and we'll be able to characterize non-invasively the kind of metabolic status of the cancer and see how it's generating energy to meet its metabolic needs by measuring lactate, fumarate, pyruvate in a non-invasive manner. And I think this is just around the corner. So you can see what's coming, but this is all the future. And I'll mention AI, and then I don't have to mention it again. So this is there in the background, and obviously, and I put this one down because this is 6 years old as well, and showed, you don't need to see that, but that's even 6 years ago, AI could outperform good radiologists. And the challenge is not whether it can or not, it can, and it has done for many years. The challenge is one of kind of implementation, which we might want to talk about later. So what are the biopsy reduction opportunities today? And I think there are many. So normal MRI I've covered. If you have, all tests have an abnormal, normal, and a gray status. And I think we found over the years that if you've got a indeterminate scan, the yield, if you biopsy that prostate, is very low. And many of us choose not to biopsy those individuals, particularly if it's associated with a low PSA density. Those men can have maybe another MRI in a year, or you just watch their PSAs, but many of us choose not to biopsy. But that practice varies around the world. At the EAU, if you've got a slightly abnormal MRI, but a negative PSMA PET, this gets very expensive now. This is Australian work because they can do PSMAs very, very cheaply. You can get to a very low status in terms of the likelihood of having clinically significant disease in your prostate. Equally, we've learned, just like in the lung, you see a lesion. If it's small, you watch it. If it stays small, you probably continue watching it. If it grows, you intervene. Well, you can do the same in the prostate. And so just because somebody has a lesion doesn't mean that you have to stick a needle into it. You can use time as a kind of diagnostic piece of information to see if you've got temporal progression of that lesion, and then maybe treat or biopsy on progression. Not many people are doing that, and that's crept in a little bit into the active surveillance literature, but that's fairly modern. The thing that really blew everybody's mind is not biopsying prior to radical prostatectomy. And just after COVID, there was a report from Germany, and the urologists in the room will remember this, that just kind of came from nowhere. It had spent a lot of time getting rejected from many, many journals, and eventually got placed. And this was not a trial. This was a group of German urologists getting together, probably over dinner, to say, oh, I've treated 2 patients without a biopsy. Oh, I've treated 3. I've treated 1. They put those patients together, which they accumulated over a 5-year period. And those patients were reported in this paper, and these patients had to have an abnormal MRI and an abnormal PSMA PET. And so the double hit was sufficient for the patient and the surgeon to collude that they could go straight to prostatectomy without a biopsy. And well, you can see the results. 100% of the patients had clinically significant disease at the patient level, and it was nearly 100% at the lesional level. But this was retrospective, uncontrolled, non-registered, no ethical approval, I think. And so I think we just kind of waited and to see what would happen next. But there was quite a lot of discussion about this paper, despite it being only 25 patients and not being a trial. And you can see there the abnormal MRI. There's a lesion at the top right of the prostate, arrow pointing to it, which is confirmed on the PSMA PET. So the MRI gives you sensitivity, the PSMA PET gives you specificity. Put the two together, you identify a pretty high-risk group of patients. And then the Chinese got involved, kind of big time. And since then have published 6 papers since 2021, all protocoled, registered trials, formal studies, doing this in a proper way. All the papers do it slightly differently, but essentially it's MRI positive, PSMA PET positive, and some have included a high PSA density. And the results are strikingly similar. So again, if you ask people to qualify in this way, you identify a pretty high-risk group of patients, but all of them, 100%, have clinically significant disease, which obviously you verify at the time of prostatectomy. And they are arguing that this should become the standard of care. It'd be interesting to hear what the urologists in the room think about that. And actually, if you think about it, this is a lot of patients. So these are high-risk patients going to radical prostatectomy. You could speed up the pathway considerably. Some people have to wait 6 weeks to get the result of the pathology in some parts of the world. This is a huge delay. And if you think about it in a non-emotional way, you can't improve on 100%. If you stick a triage test into this pathway, you're only going to make it worse through a false negative, through a misclassification. You might delay surgery considerably there might be a complication, for instance, sepsis after the biopsy. people have died after biopsies due to sepsis. And also surgeons, I don't do surgery anymore, but I did for a long time. And we always told the patients to wait a little bit after the biopsy, just so the surgical planes could settle down a bit and the inflammation could settle and we could get a cleaner dissection. I don't really know if that's true, and it was a convenient way of delaying the need, finding a date for surgery in a kind of tight system like the NHS. But it's said, and it's still said by many individuals. And of course, there would be no disruption of the anatomical planes, which could be through the rectum, but equally could be through the perineum, which obviously leads to inflammation, fibrosis, etc. And I suppose the kind of key thing that we might wish to explore is whether these high-risk men with high-risk disease will get a better oncological outcome as a result of going straight to surgery. It might be just the time thing, but it might be that avoiding biopsy also confers benefit on the individual in terms of reducing the risk of a PSA progression afterwards, which is going to be very high in this group, in the order of 30 to 40%. So could we do this without PSMA PET? PSMA PET's hard to access in many jurisdictions. It's expensive. In London, if you're paying for it, it's about $3,000 US dollars to get a PSMA PET. In Australia, it's much less. In Italy, it's much less. And so this is unpublished, but what we did, we asked 4 radiologists to go away for the weekend, close the doors, lock themselves in, and to re-report just over 200 MRIs, but not to report them in the way that they've been taught to report them, which is using something called a PIRAD system, which is essentially designed to reduce inter-observer variability, or the Likert system, which you've already heard mentioned, which is a kind of gestalt of whether prostate cancer is present. We asked them to report in terms of ruling in prostate cancer and to identify cases where they were 99% sure this was cancer, 90% sure it was cancer, or less than 90% sure it was cancer. So a completely different way of reporting, not really knowing how it would go. And the results were identical to the MRI PSMA study. So when they said that a case is 99% cancer, they were 100% right all of the time. There was one case that had to be adjudicated. So if there was disagreement between any of the 2 observers, they had to agree a consensus, and the agreed consensus was the result. And that was the case here. But all the patients after that process had clinically significant disease. 90% sure was pretty good. They only missed 1 case. So the human eye can rule in prostate cancer with 100% certainty without recourse to PSMA PET as well. Again, questioning whether or not we need to verify what it is that they are seeing. This is how it'll appear in the paper. If the paper ever gets published, it keeps getting rejected. And you can see the 1 case that was subject to adjudication and then on the consensus was deemed to be a cancer. So that's the 99% sure group. So again, showing that we can be certain about what's in the prostate without any invasive test. The other thing that's changing is this drive for early detection. So we are finding cancers earlier and earlier. Most people would agree that's a good thing. There's a small risk of overdiagnosis, overtreatment as a result of that. But also, if you find cancers early, you've got to treat them differently or manage them differently. They're at much lower risk. Patients will tolerate less in the way of side effects. Healthcare systems will not tolerate expensive interventions. And it may be that these individuals have an opportunity to avoid a biopsy as well. And the reason is that they are so small, and this is a 99%er. I'm not showing you all the images, but this is just showing you just how exquisite MRI detection can be in optimal circumstances. I mean, this cancer sitting in an easy place to detect, but this is a 0.05 cc lesion. You could try biopsying this 100 times. You probably wouldn't hit it, but you know what it is, and you know it will progress over time. So going avoiding a biopsy because you can't do a biopsy reliably and going straight to treatment or observing remains an interesting kind of modern option for patients such as this. And this would be an example of that. And so this is a lesion that you can see. We're 100% sure it's a cancer. We avoid sticking a needle in, and then we treat it and put a margin around it in a minimally invasive treatment that takes about an hour to do as an outpatient, which doesn't cause incontinence, keeps your erections, and gives you a very, very high 85 to 90% chance of freedom from disease at 5 years. So that, again, so just a kind of question mark about whether that might be the way forward in the future. So I think we can say a few things. Imaging can possibly, controversial, outperform biopsy in terms of ruling in and ruling out prostate cancer. It's reliable. Biopsy is unreliable. Poor reliability always affects validity in a negative way. Biopsy-free pathways are opening up. There are lots of them. In fact, I think they outnumber now proportionally the biopsy necessary pathways. And from a kind of surgical science perspective, this is the opportunity. We've now got a control. Historically, when a patient asked you, will the biopsy make my cancer spread? We all used to breathe, go, oh my gosh, that question again. But actually, we were unable to answer the question because we had no control that we could apply to a trial. And the fact that we can now not biopsy certain individuals means that we've got a control so we can actually start to address really important clinical questions. So this is a patient that I tried to avoid doing a biopsy on for many years. The arrows point to 3 small lesions, and we were doing pretty well. They were stable until he developed near retention, and you can see he's got a very big prostate and needed a holmium laser prostatectomy to get him out of this episode of acute on chronic retention. And we thought that it might be sensible to find out what's in the prostate before doing so. But he was adamant. Well, he was not adamant because eventually he did have a biopsy, but he was very, very anti having a biopsy, but eventually conceded given that he was having another procedure. And his position is quite commonly held. So if you ask patients in a focus group about biopsy, it's quite interesting just how against it they are because of this notion that you are, you're putting something into the prostate, you're spreading things, etc. And whether that is real or not is unknown because we've never been able to do the research. But this is an area that patients value. They're happy to support financially, and they're happy to be recruited into clinical trials in order to investigate. At least that's the theory at present. We haven't put it to the test quite yet. And so this is the biopsy on the individual. I just want you to watch this very closely. The biopsy here is not important. It's the venous plexus around the prostate following the biopsy that I just want you to keep an eye on. And you'll see this go live. There's 2 needle deployments. You've just seen one, and you'll see material fill in the bottom arrow is showing material in the venous plexus following the biopsy. There's another needle deployment coming up in a second. This is a standard targeted biopsy. And you'll see the venous plexus further away, the top arrow in a second, so that the needle's gone in now, and you can see stuff. Are they air bubbles? Are they tissue? Are they cancer material that we have introduced by means of what is a high velocity injury, which is what a modern biopsy does. So it creates cavitation. The cavitation then collapses with huge pressure and then forces out material through the entry site, exactly the same as would happen with a high velocity bullet. So there are 3 things that could be going on here. Obviously, there are theoretical examples of trauma causing metastatic progression, murine sarcoma model being the obvious one. Needle tracking in prostate cancer has been reported. It's rare, but it happens. We just don't know how often it does. I've talked to you about the high velocity injury, which we need to learn more about. And then, of course, we're changing the we're changing the cancer. We're introducing a wound. We're going from a kind of epithelial to a kind of mesenchymal transformation, which many individuals think is pro-metastatic, and indeed has been summarized in many, many articles over the years, largely in breast cancer, not so much in prostate cancer, about the effect that we have on the cancer by putting a selective pressure on the cancer, which is pro-inflammatory and pro-proliferative. This is what happens in the prostate when you do a needle biopsy. And so this is the entry wound. So you get the cavitation, a huge amount of kinetic energy on the leading edge of the biopsy, which causes the cavitation. Then the cavitation collapses and the cannula comes over it to try and capture it. And this is the kind of cavitation that is very difficult to see in the prostate, but definitely occurs. And then it collapses down, and many of the contents of the biopsy, or the area in which the needle is deployed, will be expelled through the entry wound. There are reports of seeding. They are rare but recent. This is a transrectal prostate cancer after prostatectomy. We're seeing more and more perineal recurrences since the advent of transperineal biopsy. This is one that was reported quite recently. We've got two other very similar cases that were picked up on PSMA when the PSA started rising after prostatectomy. And this is an adenocarcinoma recurring in the needle tract after the biopsy. Remember, we're biopsying very differently today. We used to biopsy randomly, so you're lucky if you hit the cancer once. Today, we're hitting the cancer many times because you're doing repeated targeted sampling. So it may be that we're going to see an uptick of this type of recurrence. The fact that this can occur should force us to ask the question, how often does it occur? Is this the tip of the iceberg? In other words, are many progression events after treatment related to somehow to the various impacts of the biopsy? And of course, we don't know the answer to that, but we have the opportunity to research it. The other thing that's quite interesting, and this is all it's not quite anecdotal, sporadic reports in the literature to kind of make us think a little bit. This is odd because it appeared in 2020 and nobody's done anything since. And they showed basically a 14-fold increase in the presence of circulating tumor cells after biopsy. And rather surprisingly, if you did have circulating tumor cells after biopsy, you had a much greater chance of progressing after prostatectomy. This hasn't been repeated. Whether this was a false positive, whether others have repeated, not got the results, not published, but it's had very, very little attention. In breast cancer, again, there are reports when they transition from fine needle aspirate to core biopsy with adjustment, because obviously this is temporal analysis, they showed a kind of increase in mortality, which they attributed to the process of biopsy. I'm not a breast cancer surgeon. There may be people in the room who know this. And again, in breast cancer, the biopsy to treatment time, obviously the longer that is, the greater the risk of mortality. And again, there are investigators, you can see them here, that are attributing that again to the biopsy itself. And of course, many things happen when you do a biopsy. TGF-beta increases, CD4, CD8 lymphocytes increase in the stroma and in the cancer. So we're definitely changing the cancer. Whether that's temporary or permanent, we've yet to find out. And you can see changes in ECAD here in the biopsy site that aren't expressed away from where we've done the biopsy. So again, hard to put them all together, but they're telling us that we are changing things and we probably do need to study it. In prostate cancer, there's been virtually no investigation into this area at all. And so we thought we might change that and ask the question, how much of prostate cancer progression is actually biopsy related? I think most would say, so progression rates in prostate cancer are much higher than they should be, and they occur in people where it shouldn't occur. So you've got an organ confined prostate cancer that is specimen confined at the time of surgery. So the cancer is nowhere near the outside of the prostate, and yet their PSA starts rising afterwards. And surprise, surprise, if you irradiate the part of the body where the prostate used to be, the majority have a very reasonable remission. So up to kind of 60 to 80% freedom from progression over 5 years. So why are these organ-confined, specimen-confined cancers recurring? And why is it that giving a little bit of radiation therapy to where the prostate used to be seems to sort them out? And again, which is, I think, which is this bit here. So a very intriguing question. So is it the biopsy? Is it the surgery? Or is it both? Is it the biopsy that sets it up, and then the pro-proliferative insult of surgery is enough to make those seeded cancer cells possibly render them permanent, or give them a kind of extra selective push towards either local recurrence, which it what appears to be, or indeed to become metastatic. So we're going to study this. We were just saying yesterday, we've raised about half the money to do it. This is all philanthropy. This wouldn't get through any grant committee at present. It's far too controversial. Grant committees need to be pretty sure about something before they all agree, and you get a high score compared to everybody else. So this is all done through philanthropy. And interestingly, it's something that individuals want to support. So you can see that this is a program of care. We're doing all the kind of ethics, doing all the patient work. We're doing the work with physicians, with radiotherapists to see if they'll accept it, etc. But importantly, we're going to run 2 trials, which are feasibility trials. And these will be challenging. We want to see if we can recruit. We want to see, what the withdrawal of consent rate is in these studies. And we want to do a lot of the kind of biology and the fragmentomics of the non-biopsy patients versus the biopsy patients with all the latest technologies. So cell-free DNA, circulating tumor cells, host immune changes that were not available to investigators that were doing this beforehand. And then the other one will be much easier. This is the radical prostatectomy one. It's just basically convincing the surgeons or seeing if they have enough equipoise to randomize patients to a no biopsy approach versus a biopsy approach. And then again, setting them up for long-term follow-up through data linkage. These are small studies. This involves PSMA PET, which is a research cost. These are pretty expensive studies to do. And the aim is to see if we can recruit, report some preliminary changes, and then if we have some positive signals, we'd go to a big funding agency and then undertake a big international multi-center study that some of you might like to be involved with. So that's the plan. We hopefully are going to start recruiting just after the summer, but there are lots and lots of issues that we'll face. But actually, this was always the case. If a study isn't difficult, it's probably not worthwhile doing. And we're slowly going to go to all these. And I think if we meet again in a year or two, I'll be able to tell you how this has gone. Surprise, surprise, we're not the first to do this. So the Chinese colleagues were there first. They have a registered RCT on the Chinese clinical trial database, which is registered in 2025. And so I met some Chinese colleagues at the AUA. They weren't aware of this or whether this had started recruiting. It's just fascinating to see that they're already well ahead of us. I'm not quite sure what they're seeking to find out. There's not much biology in their registered trial. I think they're just seeing this as a kind of efficiency move in a healthcare system that has an increasing number of patients to treat. So I think numerous biopsy-free pathways are emerging. Remember, in many parts of the world, everybody still gets a biopsy. I think prostate biopsy confirmed, it's not a zero harm proposition. The question is, how much harm does it confer? We can now do an RCT, at least I think we can. At least we have the opportunity to do it. And I think the time is right now. I think if we leave this too long, many men, if they randomize to biopsy, will withdraw their consent and say, "I'm sorry, I don't want a biopsy," and you can't do the trial. So so And that's a risk. So we have to recruit really quickly to the study. Fragmentomics now, the science of fragmentomics, I think, is ready to help us understand what's getting into the bloodstream when we do these biopsies. And of course, this will need a very large multi-center study, which Montreal will be involved in as well when we're ready. So thank you. Huge amount of work gone in. Veeru Kasiviswanathan, who's known to many of the urologists in the room, is driving much of this. And you can see this is a wonderful collaboration of a lot of disparate kind of individuals, including a very active and engaged patient and public advisory group. Thank you very much.
Thank you so much, Mark. That was a really great talk. I think one of the things that I was struck by is that it's just such a great Fraser Gurd type of talk. And when we bring the department together, and I'm sure, like me, people had insights into their own work and their own area that perhaps they hadn't considered by listening to your experience. So thank you so much. I think we have about 5 minutes for questions. Lots of kudos in the chat on the Zoom, but if there's any questions in the room, yep, Dr.
Thank you, Mark. A great presentation. You know, one of the challenge to move into that direction is the variability in imaging reading.
Yep.
You have radiologists that dedicate their life to prostate imaging, which in the majority of centers around the world is not the case. So where do you think AI will come and solve this and stabilize this aspect of that will be crucial in order not to go in the wrong direction?
Yeah, almost certainly. Yeah, AI is going to do the reading. But actually, if you look at the papers that are going straight to prostatectomy, the last paper, the paper I showed you there, is out of date now. When I wrote this on the way over, there's a Mexican study. And so in Mexico, they have MRI that's up to it. They had 100% hit rate as well. That's the latest study that's just out there. So the Chinese can do it. The Germans could or can do it. The Mexicans can do it. So I think there's little excuse now, for poor quality imaging. People often say, "Oh, you can't do it because the imaging quality is not good enough." That's their problem. That can be solved. There are no secrets anymore about doing high quality MRI. But it is an issue. You can't rely on imaging if the imaging quality is poor.
Yep, Dr.
Hey, Mark, thank you so much for this presentation. I really enjoyed it. I was wondering, you didn't mention it, where do you see the role of micro-ultrasound in this picture of non-invasive diagnosis going straight to radical treatment?
Yeah, I'm agnostic. I mean, all the evidence is at the moment is with MRI and PSMA PET. But if ultrasound has a strong enough positive predictive value for this, obviously we need to find that out. It suggests the clinical trials would suggest that it's up to it. We could use it as well. The problem I have with ultrasound is its interoperability. If you do an ultrasound in Montreal, I've got to repeat it in London, and we'll both see something different. Transferring images is much harder, whereas with MRI you can send them all around the world. Everybody can look at them. So, but that's the only issue with ultrasound that I have.
Yeah.
Thank you, Mark. Having spent almost 35 years in this space, I'm happy to see the field move in this direction. We've all seen difficulties patients have suffered from biopsy. However, for those of us that are pushing the envelope in the area of surveillance, I still feel the biopsy gives us a lot of information on gauging is surveillance safe or not. Do you see we'll be able to get to a point where we can actually not need the different percentages of the Gleason grade pattern to be able to decide intervene or not?
So it's a really great question. So trouble is we all do surveillance differently, depending on how we kind of classify our patients. If you don't biopsy normal prostates, Gleason 3+3 goes away. I'm not showing you, but I can show you in fact, that's in the public domain now. And basically, you're just left with lesions. Yeah. So if you don't biopsy normal tissue, you discharge them or whatever, surveillance becomes about lesions. The proliferation rates of prostate are very low. You can just watch a lesion. These are very early. The lesions will eventually, as we do in small renal tumors, as we do in the lung. And so I think that needs to be explored. Caroline Moore, who I mentioned earlier, is doing quite a lot of work on that. And so it may be that the visual characteristics of the tumor are sufficient to guide and inform therapeutic decisions. And the very unreliable elicitation of the amount of pattern 4, which is completely based on which bit you hit and is different every time you do it, in time may become less important. But that's, you know.
Okay, last word, Dr. Taba, sorry.
Excuse me. In your active surveillance of these patients, what's the trigger to go to a biopsy? Or you just, or maybe I should be asking that to Armin.
Do you mean in my practice or in the clinical in the clinical trial that we wish to do?
Well, yeah. So you've got a patient that you're actively surveilling. At what point, what criteria do you use, doubling time or whatever certain radiologic characteristics that may subsequently evolve? What's your trigger point as to when to intervene, either with a biopsy or prostatectomy?
I think it'll be the same that we currently use. You know, so why do we intervene? Because the patient wants us to. They've had enough. The PSA goes up and everybody gets a little bit uncomfortable, or they have a repeat biopsy and you show a little bit more Gleason pattern 4, but you never know whether that's reclassification or progression. The more imaging you do, the more you can rely on serial temporal progression. You know, so in other words, the lesion getting bigger, once it starts getting bigger, is probably the time to treat. So that would be the new indication in a kind of image-based system.
So bigger is a value judgment. Do you have something objective? Is it doubling in size? Is it 1 millimeter, 5 millimeters, sort of?
You're right. So when you're measuring the volume or cross-sectional area on these very small lesions with 3 millimeter, you know, sampling on MRI, there's a huge amount of error. And we don't have a criteria yet about, you know, when is bigger, but it's usually a kind of doubling in size that makes the radiologist say, the tumor has doubled in size over the last 2 years. Very few men will want to keep that lesion in their prostate if it's doubling, if the doubling time is 2 to 3 years.
Okay, the last word, Dr. Mitra.
Hi, my name is Cynthia Dimitra. I'm a surgical oncologist and I treat retroperitoneal sarcoma. And I find this extremely interesting. Exactly like Dr. Feldman said, we see a lot of our practice in other people's talks. For us, for retroperitoneal sarcoma, the pendulum has just swung recently where we now actually perform biopsy routinely over the past 10 years. And I find it very interesting that you described that the microbiome and the microenvironment of the tumor changes. Is there an explanation for it? Is it just increased inflammation in the tumor that causes that?
Yes, so that drives, it's the inflammation that changes the nature of the tumor. So you get, you know, everything becomes more leaky. You know, it's just like a wound, like a bee sting. The cells become much more mobile, less sticky, and therefore, theoretically, more amenable to movement, whether that be mechanical dislodgement or indeed spread into kind of lymphatic system or the bloodstream.
And is there increased data for prostate because it's such a more common disease? Is there increased data there's increased lymph node, higher lymph node yield or higher metastatic rate?
No, but there will be because everybody gets a biopsy at the moment. So it's very hard to attribute any progression or failure of treatment to the biopsy. We just call it treatment failure, but it might be biopsy and treatment failure or biopsy failure. But the only way you can do that is to have a non-biopsy control.
So thank you, Mark. We have a few, thank you for all the great questions. Interesting because we recently had a talk for thoracic surgery that told us how great robotic biopsy of these ground glass opacities that we're following now and how important it's going to be and how crazy it is that we don't biopsy those. So that was last month's talk. And now we have this. So that's medicine for you, I think. Yeah. So thank you. We got a few little tokens of our appreciation. Now there is a tie. I know you're not allowed to wear it in your hospital, but
there are
wear it out to dinner. Yeah.
And a hockey shirt, I hope.
I wish we had thought about that. That would be good, but that's good feedback for the next. I'll send it to you.
Thank you
for
very
sure.
much. It's been
Thank you, Mark.
pleasure.
Thank you.